welcome to this sponsored session from Inside LifeTech. My name is Emanuele Barbato, and today we'll discuss about the contemporary adoption of invasive coronary physiology with microcatheter-based technology. I'd like to welcome my colleagues, speakers and operators here with me today. From the Cardiovascular Center Aalst, we have Carlos Collet, one of the speaker, Bernard de Bruyne and Jeroen Sonck, operators of the live case that we are going to see later on, and Salvatore Brugaletta from Spain. Welcome to all of you. I cannot start this session without mentioning the great job that Simone Biscaglia is doing at the same time in the chat. Simone is our chat master. So how does it work? We will have two parallel discussion between the live session and the chat. So Simone is chairing the discussion there. If there is any questions that you want to ask, just feel free to do so. And we'll try to capture some of the discussion that is going on in the chat also live here in the studio. We are here today mainly to address the three important points. The first one, we'll try to understand altogether the role of microcatheter-based physiology also through a critical appraisal of the literature. We'll try to know how to correctly adapt the novel TruePhysio microcatheter, and we'll discuss the importance of physiology assessment to plan, optimize percutaneous coronary intervention, and why not also to assess its final result. Now, without further ado, I'd like to introduce Salvatore's lecture. So let's hear what he has to say on this topic. Salvatore.
Thanks, Emanuele, for introducing me. So it is my pleasure to start with this interesting topic. So these are my conflict of interest. So first of all, so we should ask ourselves why we need this microcatheter-based FFR. So to me, there are two main reasons. The first one is that so when we use a pressure wire, so a pressure wire will never be comparable as a regular workhorse wire, like for example, BMW. Because so in a conventional wire that we use in our daily practices, so there is much technology. So we have different material, different coils that are combined between them. So giving to the regular workhorse wire a very good trackability, navigability, and torqueability. Instead, the pressure wire so is a wire which doesn't have so high technology. So it's very difficult to torque, to navigate inside the coronary vessel. And the second reason so is actually because of this trackability. Because so when we have a tortuous vessel, like we see, for example, in this angio, so we feel more comfortable to using a regular workhorse wire and then to use on the top of this a microcatheter-based FFR. The same so is, for example, for multivessel disease, for osteal lesion, for making a post-PCI measurement, for making pullback, or for example, evaluating bifurcation. So every time that we have this, we have to deal with this anatomical situation, so we feel more comfortable with our workhorse wire. And then, so if, for example, so we see which is the difference between these two technology. So the pressure wire, as we have said, so there is a pressure sensor which is around 30 millimeters from the distal tip of the wire itself. Whereas in the microcatheter-based FFR, so there is the pressure sensor which is located very close to the distal tip of the microcatheter, and it is quite easy to locate because we have two radiopaque markers in between the pressure sensor, and we can go as a microcatheter so on the top of our workhorse wire. So this is not only the difference between these two technologies, but there are also other differences which made the microcatheter-based FFR so easier to use, like for example the fact that we can go fastly going in and out by using our workhorse wire. The workhorse wire is always in place, so we don't need to recalibrate the wire, so the wire is always in place. And also to make some pullback is quite easy because so we just needed to pull back the microcatheter, but we don't need to move the wire position. It's also quite easy for example, for making a measurement after post-PCI, so we can go through the stent, and we don't need to disconnect and to reconnect the wire every time that we want to make a measurement. And then, so one can argue that, for example, using of this microcatheter FFR as compared to the pressure wire technology, so may have not good agreement, because with the microcatheter we introduce something inside the vessel and we can alter the FFR measurement in terms of pressure, for example, distal to the lesion. And actually, so the answer to this question is coming from this study, from the Supreme study, which is actually in press. And you see here that the agreement between the microcatheter FFR and the pressure wire FFR, so in same vessel, is quite good, with a very narrow limit of agreement, so between these two technologies. And looking especially at the drift of the devices, so you see that it's even better with the pressure microcatheter, so that we don't have a high rate of clinical significant drift as compared to the pressure wire. So this is my last slide. So now I'm happy to take any question, if any. Thank you very much.
Thank you, Salvatore, for this very clear, short and concise illustration of what are the pros, the features of this technology. I noticed in your presentation that you alluded to the position of the pressure sensor that is close to the tip of the microcatheter. Can you just share in your experience what is the advantage of knowing exactly where the sensor is and the fact that it's close to the tip?
Yes, thanks, Emanuele. So to me, this is a very important feature, because so the fact that you can locate very well where the sensor is located allows you to make a precise measurement. So the fact that, for example, you have on the tip of the microcatheter, the sensor allows you to go to go after the lesion, so to locate very well where the tip, where the sensor is located. Actually, there are two radiopaque markers, and you are pretty sure that so you are crossing the lesion, you are making a good measurement. And then, so when you, for example, you are performing a pullback, because of, for example, there are several lesions, so you can go step by step. So you are pretty sure that you are evaluating one lesion, two lesion, three lesion, because you can locate very well where the sensor is located.
Another aspect that is always interesting to clarify, especially when you propose a new tool, a new technology, is how does it perform as compared to the current technology? I noticed the slide from the Supreme study that in the meantime has been published, and you alluded to the drift. So what is the reliability of the TruePhysio microcatheters as compared to the pressure wire in your experience?
Yes, as I show in the Supreme, so the reliability looks very, very good. So it's 95%, and actually I was surprised also to see that you have less drift. This can be, caused by the fact that we are dealing with an optic fiber, so as compared, for example, with the other pressure wire. And so in general, so not only looking into this technology, but in general looking at other kind of microcatheter-based FFR, so the reliability is good. So the only thing that we should think is every time that we are measuring, so we are making this measurement in a small vessel and in very tight lesion. So in this kind of maybe less reliability, but anyway, all the studies agree that if there is some lack of reliability, so this is not going to change our decision, because the value of FFR, so looking at the threshold, so 0.8, so is not going to change actually the fact that you are implanting or not a stent. So.
Thank you. Our colleague here, Rodrigo from Mexico, is asking what are the top 1-2 indication for this technology, for the microcatheter-based technology over a pressure wire. So, Salvatore, if you think to your practice and you think to these microcatheters, I know that you're an experienced interventional cardiologist and a good user of invasive physiology. So if you think to this device on your shelf, when would you use it?
Yes, so this is a very good question. So I'm thinking about two particular clinical scenarios. The first one, is so when you have some serial lesion and you want to make a sort of pullback. So making this pullback, you are pretty sure that you are measuring 1, 2, or all the lesions. So and according to where your microcatheter is located, you are actually measuring which is the value of each one of the lesions, so that this allows you to have the best treatment as possible, treating, for example, one or all the lesions. And this is actually quite good because for the microcatheter, you are just moving in and out the microcatheter, but the guide wire is still in place. So you don't have to be worried that maybe the wire maybe kinked in the distal part and maybe you are not going through again. And the second situation is, for example, a patient with multivessel disease. So a patient with multivessel disease that you want to measure, so different vessels, different lesion, and you want to be comfortable with a guide wire. So in this case, you are using your workhorse wire, for example, a BMW, and then so you are going in and out with a microcatheter. So that will be a quite easy and fast way so to measure the physiological value of each one of the lesions. So being comfortable because you are still using your best comfortable and workhorse wire.
I think your points are very reasonable, and I'm curious to see whether the colleagues in Aalst actually adopted the microcatheter, the TruePhysio microcatheter in the way you suggested. So we are ready to go to the cath lab and see the case they performed for us.
Thank you very much, Emanuele, for this very kind introduction. It's an honor for me to introduce this excellent team in the Cardiovascular Center in Aalst. Next to me, somebody that does not require introduction, Bernard de Bruyne. We have our nurses, Tom and Eddie. And I think we will start by a case introduction by Emanuele Gallinoro, our fellow.
Thank you, Jeroen. The case of today is a 57-year-old male. He runs 10 triathlons per year and he has never experienced an angina in his life. He was admitted to our emergency department because of an inferolateral STEMI. The culprit lesion was located in the distal circumflex and was treated with a primary PCI. But this is also a case of multivessel disease, as you will see from the coronary angiograms which have been collected today.
So thank you very much, Emanuele, for this case presentation. Let's have a look on the angiograms that we acquired while waiting for you. And on the RAO, you can see that there is a lesion in the proximal LED, a long lesion, maybe not that tight, and then there is certainly another lesion in the mid to distal LED. Next, we will see the diagonal branch a little bit better. Here we have it. This is the diagonal branch, the branch of the diagonal branch actually, which is severely diseased. Next. We have seen, by the way, I forgot it, that the stent placed by Carlos is nicely patent, but in the proximal part of the circumflex there is also a mild lesion that we will have to investigate. In this projection, we have a better view on the proximal LED, which angiographically look very tight. Next. Here we see even better the circumflex. The proximal circumflex is really what we call an intermediate lesion, angiographically spoken, and which really requires interrogation with intracoronary pressure measurements. As far as the right is concerned, diffusely diseased, and in the crux of the right we see a lesion which is probably a little bit more pronounced on the posterolateral branch than on the PD of the right. Again, this is something what we have to investigate invasively. Show the next one, Tom. That's excellent. Here we'll see it probably a little bit better. Yes, we see the ostium of the PL branch, which is angiographically, again, significantly diseased. We always say significantly diseased. Please remember that this is a gentleman who is running triathlon and never experienced any type of symptoms. So the goal of this session will be to interrogate the TrueVessel with invasive measurements on the basis of this Insight LifeTech TruePhysio catheter, which is a microcatheter, an over-the-wire microcatheter to measure the fractional flow reserve.
Okay, so as you can see, we have put two wires, one in the PD and one in the posterolateral branch of the right coronary artery. And I would suggest now that we introduce the setup of the machine and the wire, the unpacking and the complete installation.
Okay.
So after unpacking, we're going to flush the wire and then attach the wire to the console, the Vivo Cardio. So, okay, I received the catheter and immediately see the two radiopaque markers. There's the pressure sensor at 2.5 millimeters from the tip of the microcatheter. And it's a rapid exchange catheter, so we're gonna put it on the wire. Can I do it focus? Yes. Feel that the shaft is quite rigid, which gives you some push, and the distal part is quite flexible, which makes it really an easy catheter to cross tortuous vessels, also stent struts, for example. So first thing we have to do is to equalize the catheter. So we go with the two radiopaque markers just at the tip of the guiding catheter to equalize. Perfect. So after the equalization and confirming a PDPA value of 1.0, we push the microcatheter down. The pressure sensor is almost at the tip of the catheter. You see the markers in the in the distal posterior branch, and now we're ready for a measurement. Okay, so Bernard, I see you preparing the syringe for an FFR measurement. You will use intracoronary papaverine.
That's it.
You have flushed the line with some saline, and you're ready to start the injection. We see a PDPA value of 0.93, and I think, Bernard, you're ready to make an injection with some intracoronary papaverine to measure fractional flow reserve. Okay, injection of the papaverine, then you have to wait for 10 to 15 seconds. Okay, then we see the PDPA going down 0.72. We have some stable hyperemia, and then, if you agree, I will do a pullback. Okay, we start the pullback. It's very easy with this rapid exchange catheter to perform a pullback. We will see if there's a gradient in this distal lesion. And then you see during the pullback the PD value going up, and we will confirm again a PDPA of approximately 1 at the tip of the guiding catheter, and that is the case. Okay, so we have confirmed an FFR value below 0.8, 0.7072. I think that confirms that we will have to treat this distal right. If you agree, I'm going to measure now the posterolateral branch, and the FFR in this posterolateral branch, what we expected, 0.7273. So
exactly the same.
This is going to be a bifurcation stenting. I will perform again, so we're still hyperemic, a pullback. I just pull the microcatheter over the wire. We can see there's a jump in this bifurcation, and then going back to the tip of the guiding, again a value of PDPA 0.9798. Yeah, some small drift. Okay, so we have stented the distal right, and we're now gonna measure the post-PCI FFR in the biggest branch in the PD, also in the sake of time. Okay, so Bernard, you're ready, I think, for the injection with papaverine.
Yeah.
So, yes, proceed. The injection. We are recording. And then we go down to 0.93, which is, I think, for post-PCI an excellent result.
Yeah.
So we have indeed increased flow.
What I would suggest, Jeroen, is you to do a pullback at the end, because we have seen before that the pressure gradient did not occur. You can go. Did not occur only at the level of this bifurcation, but also a little bit more proximally. Okay.
Well, and then when we are distal to this long disease in the proximal to mid right coronary artery, we see an FFR of 0.97.
Yeah.
So
okay,
this is
fine.
not significant. I think we can leave it here, and we can show you the final angiographic results.
Yeah, go. There's one.
Okay, and then the second one.
Ready? Ready?
Next. So now we are ready to measure the fraction flow reserve in the circumflex. So as you know, the infralateral branch has been stented a couple of days ago. And now we will have a look at the most proximal part of the circumflex and see if this is still significant and if we have to treat or not. Okay, we prepare again for a papaverine injection.
Going to flush the catheter with saline as we always do. I take 3 cc, which means 12 milligram of papaverine for the left. In the right we have injected and we are ready. We are ready to go. You can record. So this is the resting gradient. Actually there is a kind of reverse gradient, which is already good news and which is not absolutely impossible in the distal circumflex to have a pressure which is a little bit higher. There we go with papaverine. And we wait for another 30 seconds to have a nice plateau. You know that papaverine is working for approximately 1 minute with a nice hyperemic plateau of 20 seconds, 30 seconds. That's very comfortable. We advise not to repeat the papaverine injection within 90 seconds, 120 seconds, and Jeroen is already pulling back. Here it doesn't make too much sense because we know that the fractional flow reserve in the distal part is strictly normal, but it's always nice to see that both pressures come back very close to each other in the proximal part of the vessel.
Okay, so this lesion is not significant. I think we can proceed to the LED. Okay, so as you can see, the PDPA value in the distal LED is 0.88, 89. Borderline, let's say, and now we're going to inject the papaverine and we wait for hyperemia.
Disengage
Okay.
the guiding.
Well, go down.
See it.
Okay, so the FFR is 0.65. If you agree, I will perform a pullback.
Yeah.
Okay, so we're ready for the pullback.
The nice thing with papaverine is that now you have 20-30 seconds fully hyperemic situation to do the pullback. No need for intravenous adenosine.
Stop.
Okay.
Okay, so there appears to be a gradient in the most proximal part of the LED.
Yeah.
That's where we saw the tight lesion.
Yeah.
I think it's clear that we will certainly have to tackle this lesion in the proximal part. I think if you agree, we're going to measure the diagonal branch, and then we decide on the strategy.
Optimise.
Store. Okay, so the FFR in the diagonal branch is 0.73. I'm doing, and you see when I cross this lesion, there is already a gradient, but more proximal to the lesion, there's still,
that's a
of course,
LED,
because of the proximal LED, some gradient, and then we go up to the guiding tip 1. Okay.
Wait a minute. Okay. Now you can stop.
Perfect.
Okay. Stop. Okay. Now, my interpretation is that the bulk of the gradient is the LED.
The bulk of the gradient is within the LED, the proximal LED.
So it's very clear from the pressure tracings that we see here in the room, especially from the pullback that Jeroen did, is that there are two jumps, one in the diagonal branch and one in the proximal LED. So in summary, for the LED diagonal system, we have a lesion that we have to tackle in the diagonal branch and one in the proximal LED, and not in the mid and distal LED, which changes a little bit what we thought to do initially. Okay, let's go for it.
Okay.
And we will come back to you when we are ready with the final results.
So we stented the diagonal branch, or the side branch of the diagonal branch, and we're gonna do an intermediate FFR measurement distal to this stent. We all agree that we will also measure, of course, the contribution of the proximal LED, but we already dilated there, so we'll see what happens now. Okay, so we are ready to inject again in the side branch that we stented in the diagonal.
Okay, nieuwe papaverine.
And then we see an FFR.
And now you can pull back to see whether there is still a double jump or whether there is only one. Look here, we are still at the exact same level while we are proximal to the distal stent.
Yes.
So we can already assume that the diagonal is fixed. Okay?
Yes.
And the jump is related to the proximal LED. That's not a big surprise. We knew there was still work to be done there. Okay, good.
Good. And now we will proceed with PCI of the proximal LED.
Hier een beetje dieper. So we are ready for the control fractional floor reserve. So post-PCI fractional floor reserve in the distal LED, you remember that there were two lesions which angiographically were at least dubious, and we hesitated to treat them on the basis of the fractional floor reserve measurements before, and especially on the pullback we decided finally not to do it. Now we go for, you can record, this is the resting gradient almost equal to 1, we are going to induce hyperemia. That's it. So there we go, and we are now looking at the distal pressure signal, and you see that the fraction of the PDPA goes to 0.88, 87, 88, and here we have a plateau, so that is very reassuring, very reassuring. You can pull back, Jeroen, even though a pull back when the pressure gradient is very small is of course always a little bit difficult to interpret, even during hyperemia, not to speak of the resting pullback. There we are in the guiding. There's a little bit of drift, but not too much. Anyhow, it's obvious that this LED is no longer hemodynamically significant, that we are done. Okay,
I agree.
So we are going to have a look to the final angiograms together. First with the wires. Maybe you can pull back the probe. Yeah. I think the result is quite acceptable also angiographically. So let's go for a control angiogram, first in fast with cranial. I think this is very acceptable. The bifurcation is fine. The distal LED looks angiographically fine. You can go to the REO with cranial, REO with cranial. Okay, Jeroen. Yeah, that is very reassuring. And also the distal part of the LED looks much better expanded, and this is important. It is better pressurized so that all these mild lesions look less pronounced after stenting the proximal LED.
Also, the post-PCI FFR is very reassuring in terms of the value of 0.88. I think with all the data we have, we expect both angiographically and hemodynamically a good result on the longer term.
So thank you, Jeroen. It was a nice demonstration of a complete functional revascularization of a young patient, very physically active still, based on the fractional flow reserve measurements and pullback of these pressure measurements. I think it is impressive that we have done 8 measurements, including 8 pullbacks with the same catheter just over our workhorse wires. And this allows, of course, to be very flexible and to be to perform many of these measurements during these relatively complex procedures. So I hand it to you. I hand it over to you, Emanuele. Thank you very much for the opportunity, and we will join you in the discussions. Of course, if there are questions, please do not hesitate.
Thank you, Bernard. And I can tell you, I will not hesitate because the chat has been overwhelmed by comments and questions. Simone is doing a great job in addressing many of them. Let's help him. Let's help him because the topics are interesting. So if you keep your answers short, then we'll try to address all of them. Let's start first with Jeroen. What is the compatibility of the TruePhysio microcatheter with 5 French guiding catheters, Jeroen? Can we do that?
Well, thank you, Emanuele. It's very good question. Yes, it's possible. If I remember well, it's a 1.6 French size. So this fits perfectly within a 5 French catheter, and it's very useful in the 5 and 6 French, indeed.
And now I want to hear Bernard on this. What is the risk of false positive FFR, asks one of our colleagues, by using a microcatheter as compared with a pressure wire? What's your thought on that, Bernard?
Yeah, that's a little bit the elephant in the room, I would say. Of course, when we enter any kind of device, we will create an overestimation of the gradients. Now, this still have to be investigated. This has to be done in vitro. It's way too complicated to assess that in vivo, by the way, but there is some overestimation. And this will depend on the size of the vessel, the severity of the lesion, and the flow which goes through the lesion.
Thank you very much, Bernard. I guess the impact on clinical decision-making of these systematic overestimation depends also on the anatomic setting you're addressing. So intermediate coronary stenosis, which is what we're aiming at, should not be really much affected by these bulky presence of the device, if I may elaborate further on your answer. Now I have another technical question to Jeroen. Colleagues were interested in the storage of the data on the console. Can we do some post-processing, some changes, fine-tuning of the measurements?
Yes, it's a console that is mirroring a little bit what we have been used to past, so you can readily access the data, move your cursor. So I think it's a very convenient, very easy to use device, both the catheter and the console.
Lots of questions on papaverine. I can tell you, people was very interested on this topic. I'll let you decide who wants to answer this. So they're asking what is the advantage of papaverine versus adenosine, whether there are different dosages in different coronary arteries. There is even one colleague who's asking whether there is a different threshold for hyperemia as induced by papaverine as compared to hyperemia as induced by other agents. Can you clarify this topic?
Well, I will try to be very brief. Papaverine is not as long-lasting than IV adenosine, but enough to allow pullback tracings. Roughly, you have a plateau hyperemia of approximately 20 to 35 seconds, which is more than sufficient. Second, it can, of course, be given intracoronarily, which is a major advantage, in my opinion. It facilitates the procedure, and it induces a very nice steady state hyperemia, which is probably less, and it probably influences a little bit less the systemic pressure than intravenous adenosine. In addition, finally, there are no side effects of papaverine whatsoever. You alluded also to the dosages, Emanuele.
That's right.
Very, very simple. 12 milligram in the left, 8 milligram in the right, to be given as a bolus and to be flushed with saline, not with contrast, but with saline, and preferably even saline without heparin. But these are details, but saline.
Now, Jeroen, the pace is excellent. We are addressing many of the questions. Jeroen, now back to you. One of the colleagues is asking, Aurel Thomas, she's asking, I would have expected to measure first all the lesions and then make a decision. In other words, the colleague is also opening the door to bypass surgery in these patients if you would know upfront what is the invasive functional significance of all the lesions. I guess you had the reasoning on that, why to start with the right, treat, and then go further. I guess you evaluated the risk of these patients, right?
Yes, we have been calculating both syntax score, discussed with the patient, so the usual process. First of all, the patient preference was PCI. And second of all, we thought that it was really feasible to tackle these lesions with rather short stems and rather focal treatment. If necessary, we can also think of CABG if it would be necessary, of course, in the future. So we didn't compromise the future of the patient with 3 focal stents, and this was what we had in mind. And it was a physiology-driven revascularization. So in the end, the surgery, we didn't need treatment. I think it fitted well within the discussion we had with the patient.
And there is one aspect I'm sure that will be touched during the discussion with Carlos later on. All these hyperemic pullback gradients showed really focal gradients. So really lesions are amenable for stenting. But we'll come back on this later on during the next discussion. Bernard, a very nice and interesting question to you. Why to you? Because you've been also one of the co-authors of the recently published Flower MI study. There is one colleague who's wondering whether there is a role of this microcatheter-based physiology in the context of STEMI as it pertains to the evaluation of non-culprit lesion. And whether it makes sense, that is the extension to the question, whether it makes sense to still perform physiology in non-culprit lesions. I guess there has been some sort of superficial reading of the study. Can you clarify what are the findings?
Yeah, we have no time to dwell into the details of the study and the fact that actually the study at the first glance looks a kind of negative study, but actually confirms the threshold of 0.80 as very useful to defer with certainty of not having too many problems in the future, lesions that are hemodynamically non-significant. So STEMI, we might say, well, why to bother and not just judge on the angiogram? Well, if we still perform these pressure measurements, and I think these microcatheter would be extremely useful in these kind of patients, because you can do that over your workhorse wire, well, then you will save a lot of stents. Then the next question is, does it make any sense to measure fractional flow reserve during the acute phase? Well, the short answer at least, is yes, definitely. It makes a lot of sense, except in patients who are in shock, except in patients with a very, very, very low ejection fraction. Then it's better to postpone. And then to synthesize everything, well, you can have the anatomy through the angiogram and the physiology of all your vessels during the acute phase and bring the patient back at the CCU with actually a complete workup of the patient. These patients, they don't need any other testing than what has been done in the cath lab, even after a STEMI.
That's right. In addition, we shouldn't forget that 1/3, 30% of the patients with STEMI and MVD has been just deferred, which is also logistic-wise a very important message of the study. Bernard and Jeroen, if you have time, stay with us, because I'd like you to join during the final discussion with Carlos. And I'd like now to move on to the next lecture and introduce Carlos Collet with this topic. Carlos.
Thank you very much for this kind invitation to participate in this symposium. The idea will be to extend what has been described by Dr. Brugaletta on the different characteristics of the microcatheter and wire-based devices for FFR in this talk entitled Microcatheter-based FFR to plan and optimize PCI and to assess the functional results. My name is Carlos Collet. I'm an interventional cardiologist, co-director of the cath lab in Oorbe, Als in Belgium. These are my disclosures. So we know that randomized clinical trials have confirmed the benefit of invasive functional assessment to decide whether the patient needs to be revascularized. And this data, of course, comes from the landmark trial FAME2. Based on this, we know that the FFR is a vessel-level metric that is a surrogate of myocardial ischemia. But if we add to the single-point measurement of FFR a pullback maneuver, we can assess distribution of epicardial resistance. And this allows us to understand whether the disease in this epicardial vessel is focal or diffuse. There is an increasing awareness of the usefulness of FFR pullbacks to plan and optimize PCI. So we are going through, or we're leaving the expansion of FFR from a first method to assess lesion significance, now to a tool that allows us to understand, one, the pattern of coronary artery disease. I'm thinking about focal and diffuse disease that can be quantified, by the way, by the PPG, and to optimize the PCI using FFR pullbacks. I will not go into the details. You know already that there are two types of technologies, one based on wires, the second one based on microcatheters. And in this table, you can see the different types of vendors that offers the microcatheter-based technology and the wires-based technology. But I want to make the emphasis that for this specific part of the expansion of FFR, it's very useful to have microcatheters because it allows you to go in and out pretty fast to these pullback maneuvers and optimize your results. It's important to understand that there is an interaction between how focal or diffuse is the coronary artery disease and PCI. We see that in patients with focal disease, this is high PPG values. When we implant the stent, these patients have high post-PCI FFR. In contrast, when we do PCI in patients with low PPG or diffuse disease, these patients actually have lower post-PCI FFR due to residual pressure losses outside the treatment region. I'm going to show you a couple of cases where the FFR pullback curve can be useful. I'm going to show you some cases that really changed my practice in the last 2 or 3 years. As you see in this slide, you see a right coronary artery with this diffusely diseased from the proximal part to the mid-segment and the distal part. But when you do a pullback curve, you start to understand better that this is not a function, this is a functional focal disease and not a diffuse disease. And this changes completely the plan and the strategy to treat this coronary vessel. And I show you the other part of the spectrum, cases where you have an apparent focal anatomical disease, and you would say, I'm going to put a stent here in the mid-segment of the coronary vessel. But when you do a pullback, you are faced with the situation that there is no functional target to treat these vessels. In other words, the apparent visual stenosis that you see in the angiogram is not producing any focal pressure drop. And therefore, in this type of vessel, implanting a stent actually is associated with minor or almost no improvement in vessel physiology. In this meeting, we have presented the results of a pool analysis addressing the predicted capacity of the PPG to predict post-PCFFR. And I just want to show you the relationship that there is between the baseline disease pattern, in other words, diffuse and focal disease, and functional gain or post-PCFFR. You see that when the PPG is high, in other words, focal disease, the gain in conductance at the epicardial level is pretty high, but when the disease is diffuse, we almost have no gain in terms of epicardial conductance. Now we're going to move now to the setting of how to use FFR pullbacks to optimize our stenting. And I'll show you an apparent and simple case. This looks like a very simple lesion in the mid-segment of the LAD. We implanted the stent in this region. The angiographic results look pretty good. We were satisfied. But when we perform a post-PCI pullback, we start to see that there are residual pressure losses, not inside the stent, but in a lesion that is not visible by angiography. And this, of course, leads to low post-PCFFR and eventually adverse clinical events. So we can conclude that the coronary physiology is expanding from a diagnostic technique to a tool that will help us plan and guide our PCI. New indications demand new devices that can be used several times in complex anatomy and several times post-PCI. The microcatheter in this regard facilitates the pullback maneuver and the assessment of post-PCI-FFR. But we need further clinical trials indeed to confirm the benefit of this technology. Thank you very much for your attention.
Thank you very much, Carlos. I have several questions to you, starting from the first one. In planning and assessing percutaneous coronary intervention, Carlos, what are, according to you, the main limitations of pressure wire, and what are the main advantage of the microcatheter-based physiology? This was a bit touched during the initial talks and discussion, but it would be nice if you put them in a nice frame and just analyze pros and cons for us.
Thank you, Emanuele, for the question. So I see that in the planning phase, there are two questions that we need to answer. One, is the lesion significant? That is addressed by measuring one point in the distal part of the vessel. And the second one, is this a good vessel to do PCI? In other words, do we have a functional target for it? And for that, we need to do a pullback. And this is where I see that the microcatheter technology may have a good place in the cath lab, because facilitating the pullback maneuver is something that will increase the information that you have concerning the coronary physiology and the disease in that particular vessel, that will help you do a better PCI and having a higher functional revascularization as measured by the post-PCFFR. This is extremely important, Emanuele, in complex anatomies, as Salvatore showed, and also in cases with severe calcification that you don't want to rewire. I see in these cases the microcatheter could help a lot facilitating all these maneuvers.
It was alluded both by Salvatore and Jeroen during the performance of the case, the fact that we know exactly where the pressure sensor is localized in this pressure microcatheter. So between these two radiopaque markers, we like to do more and more, especially when we use intravascular imaging, the so-called co-registration of OCT with angios, for example. So I wonder whether, do you think that there might be an interesting application of this technology with co-registration technique in order to make you perfectly understanding where the physiology problem is within a coronary artery? What is your guess on that?
That's a very good question, Emanuele. And when I see the future, I see that this is indeed something that could even help us more to achieve a precise PCI. I see it in two ways. First, let's say the visual co-registration, when you see the markers in your angio and your fluoro, and you know more or less where you are. That's going to be, let's say, the more visual assessment part. But also for a later co-registration, it will be relatively easy to track these very visible markers of the catheter along the vessel to perform, let's say, a more precise co-registration between physiology and imaging.
You mentioned to the PPG. Yeah, that's an interesting concept. It's going really to change our clinical practice and the way we select the lesion to be treated. The lesion not just to be seen on the angiogram, the physiology lesions to be treated. This has been validated with pressure wire, Carlos. Any thought whether this can be applicable to microcatheter? I guess, Carlos, for some reason, you're there. Any thought whether this can be also applicable to microcatheter technology?
Yeah, so the PPG actually can be calculated from any pullback curve. And indeed, what the microcatheter offers you is the ability to perform this pullback curve more easily. So I think it's a big yes. And as you mentioned, Emanuele, we're moving FFR from a one-dimension metric to a two-dimensional approach, trying to understand a little bit more the information coming from the pullback. And this is indeed something that will grow with the microcatheter technology.
That's very clear. Thank you very much. I'd like to involve in the next two short questions, the operators. So Bernard and Jeroen, please join us in the discussion because there is one practical question. Bernard, they heard you mentioning during the case that there was an inverse drift in the circumflex, and you mentioned it's not a problem, it can be well possible. One of the colleagues is interested in understanding your thought about that.
Well, I cannot remember exactly what I said, but there was indeed a very small drift of, I think, 2 or 3 millimeters of mercury, as we unfortunately are used to see with many devices. Now, this being said, I think that this device in particular, but also the other devices, intracoronary pressure measurement devices, I mean, have controlled the problem of drift to a large extent. And this was not the case 4 or 5 years ago, but nowadays, I must say, drift is no longer a real issue. Now you are trying to tease me to tell you something about the difference in height, probably, of the coronary arteries as compared to the guiding. Now, this explanation is a little bit long to do without the support of a slide, but just remember that in the distal right or in the distal circumflex, we might well have pressure signal which is a little bit higher than the pressure signal in the central aorta recorded by the guiding, simply the fact that the pressure wires are not immune to the hydrostatic pressure. This is the trick. We simply have to keep this in mind, but this has nothing to do with drift.
That's very clear. I don't know who wants to take this very last question. One of the colleagues, having seen the potential application of this device in functional assessment of the stent result, perhaps this is a question for you, Carlos. The colleague is asking whether there is any cutoff value post-stenting of FFR that we can rely upon.
Well, that is a tricky question, Emanuele. I would not say that there is a consensus on the post-PCI FFR value that we should gain. What we know so far is that this cutoff value appears to be vessel dependent. So the cutoff value for the LAD will be different from non-LADs. This is the first message. And the second message is that the predicted capacity of post-PCI for event is at best moderate. So I think we should temper our enthusiasm on post-PCI FFR as a metric of prognosis. But do we need more information on this topic for the future?
Thank you very much, Carlos, Jeroen, Bernard, and of course, Salvatore. I think it is now time to wrap up. There is a very last question from Sonia, who was asking, in light of angio-based technology, angio FFR, VFFR, and so forth, whether we need this additional tool, this microcatheter-based physiology. Well, my simple answer to Sonia and to the colleagues is simply yes, why not? It's an additional option that we interventional cardiologists have. It's just a matter to understand how to correctly position all these devices and all these options. What I see is the angio-based technology would rather play a role in diagnostic cases, in diagnostic examinations, while devices like pressure wires, microcatheter-based physiology devices could well play a role in the context of interventional cases, where certainly might facilitate the adoption of the invasive physiology, which is the main theme we're all interested in. With this, I'd like just to draw 2-3 final takes. Yes, we have a new device. We learned how to place this device in our procedures. There is much more to come, because most likely this device will also be used to assess the functional distribution of the arteriosclerotic disease within the coronary artery. We heard the near future, the potential application of PPG, even with this technology. With this, I'd like to thank Simone Biscaglia, our chat master, who did a great job in answering the tens of questions we had in the chat. Our sponsor, the Inside LifeTech, of course, PCR for making this possible, all the setup, and of course, the speakers and operators. Thank you very much, and good continuation of EuroPCR 2021.